Hello everyone and welcome back to another video from 3 Docs Teaching. I'm Dr. Zain and we are going through another question today. This one starts off by saying, a 25-year-old woman presents with a 10-year history of recurrent episodes of facial swelling that involve her lips and periorbital tissues. The episodes last for 2 to 3 days and resolve spontaneously. She denies any history of abdominal pain, wheezing, or urticaria. Family history is positive for a similar condition in her father. Physical exam during an attack reveals non-pitting edema of the lips and periorbital tissues. Which of the following studies is most likely to be abnormal? And the options here are the eosinophil count, serum C4, serum C8, serum IgA, and serum IgE. So the diagnosis for this condition here, in case you haven't clocked it by now, with the facial swelling involving the lips and periorbital edema, the fact that there was something similar in the father, family history is positive in the father, and the fact that there's non-pitting edema of the lips and periorbital tissues, is going to be hereditary angioedema. So let's go through what the condition is, and then we'll come back to the question and look at, in detail at what's going on here. So first things first, hereditary angioedema is an autosomal dominant condition. That is why you saw that there was a family history with a similar condition in the father, right? This has a genetic relevance, right? It's autosomal dominant. So it's not going to skip generations. That's why you see it directly from the father to the daughter. What exactly happens in this condition, though? What happens in this condition, though, is that there is a deficiency of something called C1 inhibitor. Now, the C1 that they're talking about here is the C1 from the complement system, right? So C1 inhibitor. As the name suggests, C1 inhibitor's job is to inhibit that C1 complement protein. So if there's a deficiency of that, that means you're going to have too much C1. That's basically going to be an increased activation of C1. So decreased C1 inhibitor, that's the genetic condition of hereditary angioedema, will lead to increased activation of C1. So you have more C1 binding here. So what does C1 do when it binds? If you remember, when C1 binds, the next C4 comes along and C1 cleaves C4 into the two components, C4a and C4b. C4b stays bound and C4a goes away. Remember, A for away, B for bound. So that's what's happening here. So if you have increased activation of C1, because you don't have enough C1 inhibitor, then that's going to lead to increased cleavage of C4. And that will decrease the serum C4 levels. So already, if we come back to the question, we have a hint here that the answer is going to be an abnormal serum C4 levels, because with hereditary angioedema, you are decreasing your C4 levels. Why are you decreasing your C4 levels? Because there's more cleavage of C4. It's getting cleaved into C4a and C4b. So the levels of C4 go down because it's getting cleaved now, right? Why is it getting cleaved? Because there's increased activation of C1. Why is there increased activation of C1? Because you have a deficiency of C1 inhibitor, so it's not getting inhibited. If it doesn't get inhibited, it gets activated, and then it cleaves C4, and so you have low C4 levels. Besides this, there's also another function for this C1 inhibitor. The C1 inhibitor normally blocks something called kallikrein. What does kallikrein normally do? Normally, kallikrein converts high molecular weight kininogen into bradykinin, which is a pro-inflammatory chemical, if you remember. Now, since this is pro-inflammatory, under normal conditions, you don't want a whole bunch of bradykinin running around in your bloodstream. So under normal conditions, C1 inhibitor will block kallikrein so that this conversion doesn't happen. Now imagine if this is deficient, what's going to happen? This doesn't get blocked, and so it converts a bunch of high molecular weight kininogen into bradykinin, which is pro-inflammatory. This can do a number of things. If you have increased levels of bradykinin, that can cause increased vessel permeability. So your vessels are going to become more permeable. That contributes to angioedema, which is going to be what? Swelling of the face, neck, airways. This is what we saw in our question, right? Specifically, they were talking about the face and the lips in our question. Besides that, increased bradykinin can also cause vasodilation. This, along with the increased vessel permeability, also contributes to angioedema. Right? You have more permeability plus vasodilation that contributes to fluid leaking out of the vessels. Besides that, bradykinin also leads to increased sodium loss in the kidneys, so natriuresis. That can contribute, along with the vasodilation, to hypotension. Because remember, low sodium is linked with hypotension. You need sodium, right? So if you lose too much sodium plus the vasodilation, both of those things lead to hypotension. Besides this, another thing that the bradykinin can do if you have too much of it is cause bronchoconstriction, and that can lead to a dry cough. As an interesting aside here, this is actually the reason that ACE inhibitors can cause a dry cough. You see, ACE, angiotensin converting enzyme, normally has a role in breaking down bradykinin, right? ACE has a role in its breakdown. Now, if you give ACE inhibitors that inhibits ACE, so bradykinin doesn't get broken down as much. That can lead to an increase in levels of bradykinin and cause the dry cough. That's why you often see a dry cough as a side effect of ACE inhibitors. Finally, a last thing that you can see with increased levels of bradykinin is going to be pain, which is classically abdominal pain, right? So these are all the different symptoms that you can see with hereditary angioedema, and they are a result of increased levels of bradykinin. Why do we have an elevated level of bradykinin? Because this conversion is happening more than it should. See, this conversion is done by kallikrein. Normally, C1 inhibitor blocks this, and therefore, this doesn't happen. But if we have C1 inhibitor deficiency, as in the case of hereditary angioedema, this doesn't get blocked and it converts too much HMWK, high molecular weight kininogen, into bradykinin, leading to all of these effects. So, if we go back up to the question, we can now see all the relevant salient points here. 25-year-old woman with a 10-year history of recurrent episodes of facial swelling, we saw that was a symptom, around her lips and periorbital tissues. Episodes last 2 to 3 days, resolve spontaneously, denies abdominal pain, wheezing, or urticaria. See, abdominal pain could have been a symptom. In this case, it wasn't, so it doesn't always have to be there, but if it was there, that would not exclude hereditary angioedema, all right? Family history is positive for a similar condition in her father. Again, there's an autosomal dominant condition, so that makes perfect sense. Physical exam reveals non-pitting edema. Again, vasodilation, remember, plus increased vascular permeability, non-pitting edema of the lips and periorbital tissues. Which of the following studies is likely to be abnormal? Serum C4. Why? Because C4 is getting cleaved. Why is C4 getting cleaved? As we saw here, that's because there's increased activation of C1. C1 is cleaving C4. Why increased activation of C1? Because there is a deficiency of C1 inhibitor. And that, in a nutshell, is hereditary angioedema. Thank you for watching. If you found it useful, share the video, and I'll see you next time.